Today I am going to be talking about fungal sinusitis and looking at kind of the impact towards the end of COVID that it's had on us. I have no relevant disclosures, just a brief overview. We'll be looking at the spectrum of fungal sinus disease. In large part, I wanted to do this because everyone, when they hear fungal sinus disease, immediately goes to acute invasive fungal disease. And the reality is that's not the majority of the cases, but it is one of the most impactful ones. So we will be talking about all those, and then looking at towards the end, how COVID affected this, and it really had the most significant impact on acute invasive fungal sinusitis, both here, but to an even bigger effect globally. But we definitely saw the impact here. So looking at the spectrum of disease, like I said, not all fungal sinus disease is invasive fungal disease, and the overwhelming really is chronic disease. And again, the overwhelming majority is symptomatic disease. And those that aren't symptomatic will eventually become symptomatic if left long enough. ENTs, I never consider myself an overly complex guy. I like to break it down into kind of simple ways that I can keep this information straight. And so I break down the major subtypes of fungal sinusitis into these benign appearing, benign clinical course subcategory, and those are your fungal balls. The potentially aggressive appearing, though, those that have a benign clinical course, and that's allergic fungal sinusitis. And then benign appearing, oftentimes at least early, and then an extremely aggressive clinical course. And these are your invasive fungal sinusitis patients. And again, the first two are non-invasive, the last is invasive, obviously. And I left off saprophytic fungal disease, which is basically just colonization of crusting in the nose, which is not a huge entity. Like I said, ENT, we're not a especially complex group. What is a fungal ball? It's essentially a ball of fungus. For those that like to get a little more technical, it's a non-invasive accumulation of dense fungal concretements. But essentially, it's just a contamination of the sinus cavity with fungus that you're breathing in. It provides a warm, moist environment for the fungus to grow. Unfortunately, these tend to be non-specific. Up to 20% are asymptomatic, just discovered incidentally on imaging, though they typically will become symptomatic if left alone. They present non-specifically, like I said, and so oftentimes similar to chronic sinusitis, the one-sided symptoms, which do throw a key that something else is potentially going on. And it's not uncommon that they have superimposed bacterial infections, so it can create a little bit of a confusing picture, as these oftentimes will respond to antibiotics, at least temporarily, with improvement of symptoms. They're very slow growing. Severe complications are extremely rare, though they can occur secondary to compression of surrounding structures, notably in the sphenoid sinus. And there's no predisposing conditions or immunocompetent, and these are immunocompetent people that get this. Two main ways that this is thought to happen. One, we breathe it in through the aerogenic pathway, basically entering through the natural ostium of the sinuses. And then there's this iatrogenic or odontogenic pathway where basically it's introduced through a fistula, typically considered through dental work and endodontic treatment and root canals. In addition to this, the zinc oxide that's often used in fillings is a key metabolite for aspergillus, and it probably seems to inhibit mucociliary clearance, which further sets up a pathway where this develops. Imaging is really key for diagnosis, and CT is the modality of choice here. And the overwhelming majority are a single sinus as well as unilateral. Maxillary and sphenoid are more common, maxillary significantly more. Ethmoid and frontal tend to be much less common, and typically MRI is not required for this. And this CT here really shows kind of the classic findings of it, of hyperostotic changes of kind of a chronic sinus picture, thickened bone. And you'll see these calcifications or concretements within the sinus, and it's not exactly clear what this is. Just if it's just insulated mucus that's been sitting there. Some have theorized it's a little bit more of the heavy metal sequestration by the fungi, but it's a common finding that really tips you off that this is a stronger suspicion of a fungal ball. Treatment. Again, a lot of what I'm going to be talking about it has a surgical tint to it. You got to talk about what you know, I guess. But so these are really primarily treated surgically. There's no medical cure for this. You basically open up the sinus and clear out the fungal debris, and it's really key to remove all the debris that's in there, because that's really the cause of what's going on. Less than half culture positive, and those that do overwhelmingly are positive for aspergillus. These people do really well, after sinus surgery. They have extremely rare recurrences. And you don't have a predisposition for other sinus involvement. So once you get it, the likelihood of you get it again is exceedingly low. You're not at a increased risk. Allergic fungal sinusitis, we start to get a little more interesting with this disease, and it's really a subset of chronic sinusitis with nasal polyps. The most common diagnostic description of it uses the Bent-Kuhn criteria, and it basically defines it as nasal polyposis, fungi on staining without invasion, eosinophilic mucin, type 1 hypersensitivity to fungus, and characteristic imaging findings. And some of these are nonspecific, but the combination of them is key. Again, similarly, these people present with chronic sinusitis, and everyone with chronic sinusitis complains about how thick their mucus is, and it's the worst. But these people actually really have the worst. It's so thick. I mean, it's described as essentially peanut butter. This is it being sucked out of a sinus here, and it is so tenacious. And I have patients that will bring me in samples of it, and I tell them I don't want to see it, but they keep bringing it in. But these people really do have such thick disease, thick secretions, and it really does further exacerbate their problem. And like I said earlier, these patients can look really, really bad. Late cases oftentimes will have significant remodeling of the bone, and they can have proptosis, oftentimes bilaterally, and facial deformity from chronic changes of this affecting the sinonasal structure. This is common in atopic individuals as well as immunocompetent. It's not common, but it's now commonly found in atopic and immunocompetent. Genetic factors are suspected to be involved, but it's really ill-defined, and culture and geography are likely key here. It's more commonly found in warm, humid environments, notably in the U.S. and South and Central regions, notably around the Mississippi River Valley. The common fungus at play are dimetaceous fungi, or basically brown pigmented fungus, and aspergillus. So how does this start? You basically, the atopic host is presented with exposure to the fungus, and this ultimately leads to an immune response, typically through a Th2 mediated pathway. It leads to tissue edema, it leads to nasal polyps, and subsequently leads to sinus ostium obstruction and stasis of secretion. This really sets up a very favorable fungal growth environment, and subsequently we go round and round, and you get this self-perpetuating cycle where once it starts, it's tough to break because the fungus is in there, leading to more and more immune response and tissue edema and progression of symptoms. In diagnosis, CT is often the initial modality of choice, though MRI can be helpful. And it's fairly classic imaging findings for this. They oftentimes will have pansinusitis, but it's not universal depending on when you catch it in the course of the disease, and can at times be single-sided or even initially just one sinus as it initially starts somewhere. The CT has a classic hyperdense secretion. So this is a non-contrast CT, but you can see this hyperdense secretions on the scan, and you actually get this hypodense rim around it, which is just a mucosal edema. Bony remodeling is very, very common with this. And again, I said these can look really scary. And this is a guy that came in with the ER with just sinusitis flaring, and the ER got this and started panicking about a tumor. And you can see there's no separation between posterior fossa and brainstem with the rest of the nose. And so he ended up getting an MRI, and you can see that the mucosa is actually intact. This is highlighting, but on MRI, it actually, because of how dense the concretements are, they actually wash out on T2 weighted imaging. So it can be actually a really helpful diagnostic component by getting the MRI to say, well, actually this looks consistent with the fungus, and it's not a aggressive tumor or what have you. Just another example. Again, you can see these hyperdense secretions filling the maxillary, all the individual ethmoids. The right maxillary hasn't really been taken over yet, and it's eroded the skull base and kind of pooching up. But again, it's not an invasive disease, so it's pushing and expanding and remodeling the bone. It's not invading into the dura or underlying, intracranial cavity here. With an MRI, you can see on the T1 weighted here on the left, and then T2, you can see it essentially washes out where those dense concretions are, and it looks like essentially a little bit of inflammatory disease, but doesn't look nearly as significant as it truly is. Treatment, it's kind of multifaceted. Surgery does play a role. Again, pushing the surgery aspect here. It's treated typically via endoscopic sinus surgery. And again, it's really complete debridement of all the fungal elements. Postoperative steroids are important in their role, but our optimal dosing and range and course is not well known. Some treat this with a few days, some a few weeks, and some people have talked about doing it for years at a time. Obviously, that has significant side effects and morbidity associated with it. Steroid irrigations have been kind of a cornerstone of managing these patients in the initial post-op period, typically with budesonide, where you basically take the Pulmicort respules and mix them in with a neti pot or the squeeze bottle version of it and irrigate after, because it keeps down the inflammation. You avoid the systemic toxicity, and it rinses out any of those residual fungal elements. And so when I actually get these patients, I'm actually very excited, because I feel like these are very potentially curable patients. And if you treat them with adequate aggressive surgery to really widely open up the sinuses, to deliver medications and irrigations to rinse out any of that microscopic disease that's left behind, I've had really good success in these patients not recurring. But I keep them on a minimum of steroid rinses for 3 to 6 months, and they got to be consistent with it. Otherwise, it will typically come back. And then we taper them off, and hopefully they can come off it completely, and most can't. I do, in terms of postoperative oral steroids, I typically only do a medral dose pack. I found that more is typically not needed, and obviously the risk of potential side effects with it. Initially, people thought maybe antifungal treatment would be helpful, whether topical or systemic, and no good studies have shown that it's a significant benefit for it. After surgery, you actually send the mucin to the pathologist to take a look at it, and you basically find eosinophils, necrotic debris, Charcot-Leyden crystals, and notably fungal hyphae without invasion into any of the surrounding mucosal tissue. Culture is hugely variable, and it really depends on the culture technique of the lab, and sometimes it's difficult to say if it's just merely saprophytic contamination. So it can be a really difficult component to know if the culture is true. So microscopic analysis is really oftentimes key. From the surgical standpoint, you're basically widely opening up these sinuses. And so this was actually that second photo I showed, or a CT, where it's in all those little ethmoid cells, sphenoid and maxillary. And you basically create a common cavity within the ethmoids and make sure you open all of the individual ethmoids up, remove it from all the sinuses, and you enable this more effective delivery of medications. And these are a little bit more, they're more significantly inflamed, so they bleed a little bit more, but nothing dramatic. The recurrence rate with these is highly variable, and has been all reported, the wide spectrum of anywhere from 10% to 100%. And I think a lot of it depends on technique, postoperative regimen. And again, there's not a gold standard here, but I think a lot of it comes down to technique and aggressiveness with it. Complementary treatments with this, immunotherapy, there's no randomized controlled trials available for this, but there's been numerous reports with decreasing recurrence, decreasing the need for systemic steroids and reoperation rates. So, I think at a minimum, if someone has a recurrence, they should be offered, but oftentimes someone up front should be offered it potentially. It's obviously a commitment of time and money, as sometimes immunotherapy is not covered by insurance, but that does have significant benefit for the patient potentially. Various biologics, Dupixent, et cetera. There's no good studies looking specifically at this. There's some smaller case reports and things like that. These likely in the initial studies probably got tied in with just chronic sinusitis with nasal polyps, but there is good rationale that it would likely help, as it is a Th2-driven disease, and would likely have a significant improvement. It's not going to cure the disease, but may help temper down some of the secondary immune response, which is oftentimes responsible for a lot of the symptoms. And then we get to invasive fungal sinusitis. And so this is a big topic. This is a big concern. It's overall pretty rare in general. And there's kind of three main types: acute invasive fungal rhinosinusitis, and that's really disease within a month; chronic invasive, when you start getting over a month; and then there's chronic granulomatous invasive. And that's really not seen, especially in the United States. And we'll primarily be focusing on the acute invasive fungal disease. And so this is really true invasion of neurovasculature, and it's not merely colonization. And this leads to a tissue ischemia by invading that vasculature and causing essentially a ischemic necrosis. The most common are Aspergillus and the Zygomycetes order. And when we look at it, diabetics make up a big chunk of this, about 50%. These are poorly controlled, oftentimes DKA, and the Zygomycetes class has an increased affinity for the acidic environment as well as elevated glucose. And then the other category of other immunosuppressed states, neutropenia is a common one, those with AIDS. Hematologic malignancy is a big one, chemotherapy, organ transplants on here too. And these tend to be more frequently Aspergillus. Again, nothing's 100%. And then there's a separate category of iron overload and renal failure. Those receiving deferoxamine for chelation, and rhizopus can bind to this, but this tends to be a much more minor category. Chronic invasive pathologically appears very similar to acute invasive, but it's over a much longer spectrum, typically months to years. And these are typically immunocompetent individuals, and it's most commonly mistaken for malignancy, given that kind of onset timing and such. And so it takes a keen eye to pick this up and intervene, but you'll find it on biopsy as they're typically going to get something when this initially gets discovered. And then just briefly on the chronic granulomatous disease, it's really, like I said, it's really rare in the Western world, more commonly seen in North Africa, Middle East, and Asia. And it can be immunosuppressed or competent. Aspergillus is typically the responsible body, and it leads to a non-caseating granulomatous picture. So history is really, in any disease is important, but the problem with this is that the prodrome is oftentimes very nonspecific. It's a common theme among the fungal sinusitis diseases. Rhinorrhea, congestion, facial pain, and pressure. Some have no classical sinusitis symptoms whatsoever. And so, these are common things being common. You're not going to jump and get a CT scan at everyone that's walking in the door. So it sometimes makes it tough, and that's why these patients oftentimes do present later on in their course. Local invasion really determines the other symptoms that really throw up the red flags: facial numbness, diplopia, visual impairment, headache, etc. From an exam standpoint, cranial nerve is helpful, especially delineating where the potential lesions are. Numbness, diplopia are really key in determining, is it cavernous sinus, do they have visual deficits, etc. For us, from the ENT standpoint, endoscopy really is a key component of diagnosis, and we will do this without any anesthetic spray, which we normally use for comfort standpoint. But we actually want to see if there's any sensation intact, because if there's a lack of sensation, again, that immediately throws up our red flags that there's something more significant going on. Early findings, unfortunately, like the clinical findings, can be very subtle, and up to 30% can have normal endoscopy. If you look at this picture, this is looking at the left nasal cavity, the middle turbinate here, and the septum here, and this is the inferior turbinate. This looks just kind of like a little bit of swollen kind of polypoid mucosa. If you look closely, it's a little bit dusky. It may throw a little bit of clue, but a lot of times it really doesn't look that bad in very early presentation. So sometimes it can be tough. The classic findings that our residents are looking for, but again, it's pretty advanced in the disease when we see this, is the classic black turbinate, whereas this is essentially a dead necrotic middle turbinate. We work these up, full blood work, evaluating for any, potential for immunodeficiency, hyperglycemia, et cetera. One of the biomarkers which is typically sent, galactomannan, and I think the beta D glucan is often sent. These are polysaccharide cell wall components of Aspergillus released in varying quantities of infected organs and serum. But with the sinuses, what we found is that it's probably not that accurate. It has a pretty low sensitivity and specificity, much less than lung and other organs. So, I don't think we can hang our hat too much on this. Probably more helpful in looking if there's the concern for disseminated disease or what have you. CAT scans, again, non-specific early findings, and asymmetric mucosal thickening is seen in the majority, but that can be seen in many, many conditions, obviously. A lack of mucosal thickening is highly sensitive. And so if the sinuses are pristine on the CT, you can say, well, you can feel pretty confident they don't have invasive fungal sinusitis. So when we start getting more advanced disease where we see that extra sinus extension, you see the fat obliteration around the maxillary sinus, and obviously orbital or intracranial extension and bone erosion. If you see infection extending to the brain, you obviously know it's serious. Strongest correlation from an imaging standpoint basically is when it involves multiple components here. So when it involves the pterygopalatine fossa, that perimaxillary fat, the nasolacrimal duct, orbital invasion or bony dehiscence, and septal ulceration, really jumps up the specificity and sensitivity when you have 2 or more of these, and can be helpful in paring that down, often from your neuroradiologist standpoint. Just some examples. So one of the things in this first one, you can see that, just the asymmetric enhancement, and in itself is not overly impressive, but one of the things you actually do not see that commonly is this asymmetric edema and swelling within the nasal cavity. That's actually less common and can be a little bit of a hint. But looking for that extra sinus extension is really the things that throw us up and say, well, we got to get this person to the OR, get them biopsied ASAP. When you start seeing extension anterior to the sinus or behind it in the infratemporal fossa, really starts raising that concern that something else is going on. Bony erosion, obviously, very concerning, whether it's for fungus or tumor. This you can't really tell based on the CT alone. Secondary infarcts can occur due to the ischemic component. And then again, like I said, these are angioinvasive, so these will invade arteries, and you can see in this is a contrast enhanced CT where essentially the right ICA has been clotted off and is without any blood flow to it. MRI is extremely helpful, and contrast enhanced MRI is much more sensitive than CT alone, and it's especially helpful for disease beyond the sinuses. So really looking at orbit brain, infratemporal fossa, and such. And kind of the keywords here that you would really want to look for is the loss of expected contrast enhancement. And you can see it on this MRI here. The bulk of the disease, and what's dead is very clearly outlined, and you will see this on scan after scan of it expanding front. And if you watch serial images of this, it's essentially expanding the dead state, where you're not getting blood flow from the contrast being brought there. And it correlates with a higher fungal load, necrosis, and unfortunately, oftentimes a poor prognosis. It's seen commonly, but there is unfortunately a fair amount of inter-rater variability here that not all neuroradiologists will call this, and it depends on sometimes their level of experience with it. So it's something that you can look out for and say, hey, what's this? This looks concerning here. Tissue biopsy is really required, and so we want to do this pretty quickly and urgently, typically, so we can get moving on diagnosis and treatment. It's usually seen on H&Es, highlighted by silver and PAS stains, as you can see here on the right. Middle turbinate is the most sensitive and specific. However, again, you got to appreciate the imaging and find out where the disease is, because it's not always the middle turbinate. Middle turbinate is commonly associated just because that's where the fungus lands and oftentimes affects early. Biopsy is typically sent for frozen culture analysis as well as tissue culture to move things along in that. I don't know if the internal medicine residents get quizzed on anything like this. Our residents do. Mucormycosis are these broad, ribbon-like, irregular, rare septation, while aspergillus is the narrow, regular septation in a 45-degree branching pattern. These are some of the others, but these are the kind of 2 big categories. Frozen section, has reasonable sensitivity and specificity, though some have suggested mucor may have higher false negative rates. I honestly have a hard time relying on this. I've gotten very mixed results. So I will send a frozen, but I don't hang my hat on it. I much rather depend on the rushed specimen with our pathologist, and I really try to push them along to get us answers, either the next day or the day after, because a lot of times we're going to be treating them the same way regardless until we get that answer. But I think having the PAS and silver stains can be really helpful. Culture is not universally positive, and 55 to 67% in histologically proven disease only come back with a positive culture. So we send it, but and it can help pare down and make us feel more comfortable with it. But oftentimes it's the biopsies that's leading us to the diagnosis. How do we treat these? Well, it's a very much of a multi-pronged attack, and there's the reversal of the underlying condition if possible. There is aggressive surgical debridement, and then antifungal systemic therapy. And this is really a disease that takes a village. You know, there is so many people involved with treating these people, and I've been involved with many of you guys as we've dealt with this, especially over the last couple of years. But from a surgical standpoint, you know, as an invasive fungal disease from the sinuses, we're typically involved. Neurosurgery and ophthalmology may or may not. Internal medicine, very key components on the floor. You guys are the ones that are oftentimes picking this up and have the concern early on. Endocrinology, very key, especially managing those very tough diabetics that we just can't get down. Hematology, oncology, especially if their primary issue is with the underlying hematologic malignancy. Infectious disease, obviously very central to this. And then critical care, because a lot of times these patients are so sick that they do end up in the ICU at one point or another. From our standpoint, from the goals of surgical intervention, you know, we have a couple main components that we want to accomplish here. And one is to decelerate the progression of disease by removing a lot of the fungal load and reducing the burden on the polyps. Further reduce the necrotic tissues so there's less, you know, easy growth in that essentially dead tissue that's left behind after the fungus has done its initial work in the vessels. Enhance potential antifungal therapy via antifungal irrigation. So there's not a lot of hard data that it does anything, but we do it typically anyways, so it doesn't hurt them. Facilitates monitoring from an endoscopic standpoint. We can look, is there increasing areas of necrosis just at the bedside with a bedside scope? And then finally, probably most important, providing culture and tissue for diagnosis. And we really debride all the necrotic tissue down to healthy appearing and bleeding tissue. You know, it's not necessarily getting every last fungal element out. I take it to when I start to see there's blood supply there, you know, I feel much more comfortable that at least there's a chance that the antifungal medications can work, because as we're going further and further, you're causing more and more morbidity. You know, you start taking out V2, you're getting into the infratemporal fossa, you're getting into the pterygoid musculature, potentially setting up for trismus afterwards. And so it's a balance of being aggressive, but trying to, you know, giving all tissue that has a chance to you know, come through on this. You can use frozen section. Again, I don't rely on it. I tend to use more clinical just because I've had mixed results with it. Timing of surgery does have some controversy. Some argue emergent, saying we go now versus urgent, you know, within 24 hours. And there's general agreement that it should be done within 24 hours. I really do treat these more as an emergency and say, we go to the OR now, and I don't have problems bumping other people in the OR, because I think the earlier you treat these people, I think they do better. And, you know, they're already facing an uphill battle. And I think any advantage you can potentially give them is important. Serial debridement and trips to the OR is very common. And you're really looking for stability of disease and lack of progression. And that's where you can start calming this down and you know, not being as aggressive with the surgery and removal of that diseased tissue. So again, overwhelming majority of these are dealt with endoscopically. This is, you know, a left-sided disease where we basically cleared out all the sinuses up to the skull base. The septum was not involved, at least at this point. And a significant portion of the medial maxilla was taken down. And this is what a common one would look like if it's involving bilateral. Obviously, you know, both sides would be cleared out. One of the controversies and questions, I guess, comes when it starts involving other structures, and the question of more radical surgery. When do we stop, or when do we keep going? And oftentimes there's an unclear if there's a definite survival benefit for this. Palate is one of those things that typically we'll be aggressive with, and we will do a palatectomy and maxillectomy, because that can be rehabilitated and reconstructive well, and that can really make a significant difference in survival, obviously. The eye is a common issue that we deal with, and obviously we almost always have our ophthalmology and oculoplastic colleagues involved here. Up to 50% of cases can involve the orbit, and they most commonly present with neuropathy, optic neuropathy, motility deficits, proptosis. Central retinal artery occlusion is really primarily seen in mucor. And there's some question of if it involves the eye, does mortality go up? And there's definitely studies that have shown it increases mortality significantly. There's also studies that have shown it doesn't change the outcomes. And when you look at some of the bigger systematic reviews that have pieced together everything we have, it looks like it probably doesn't affect mortality as long as you're treating it appropriately. But there is some question, as there's definitely been some reports with much higher levels of of death with it. Visual acuity tends to be worse with the zygomycota subclass, and surgery has been shown to improve visual outcomes in large part just because you're improving control of disease. How we manage these is evolving to some degree. If there's just moderate diffuse enhancement with the orbit, but still a very functional eye, you have kind of the component of you just let the antifungal medications work and see how the patient responds with that. It's obviously it's not dead. So the medication should be able to be delivered and potentially treat it. There's been some early reports of retrobulbar amphotericin injections. Again, this patient's not awake. They're under pretty heavy sedation here. I can't imagine anyone wanting the needle to the beneath the eye here, but it has shown pretty favorable results. But again, there's not a lot of data about it, but it is a consideration. When you start getting a little bit worse, you're getting small necrotic areas, notably in surgically accessible regions of the eye and orbit. There's a potential role for conservative debridement. And again, not a ton of data on this, but it fits with our general approach of debriding and removing the disease and dead tissue. And this is a patient of ours that had a little bit of persistent medial orbital disease right up against the medial rectus. And I don't expect you to see I can tell what I'm doing here, but it's basically scraping away the dead tissue up against the medial rectus, which was luckily spared dead fat and orbital contents here. Done through the nose, but this can be done by ophthalmology via anterior orbitotomies, transconjunctival approaches and such. And early, some smaller reports do show likely benefit from it. And really, one of the big questions comes when you start having really extensive necrosis, notably at the apex or diffusely, and then as well as with a non-functional eye. So the patient's blind, can't move the eye, it's a frozen globe. We start to consider exenteration or orbital clearance, which is basically clearing everything out in the eye, removing muscles, fat, globe, all the way back to orbital apex. And the problem with this is we don't have any data that it definitely improves survival benefit. However, the caveat to that is that most of these small series that are looking at this are combined and trying to make conclusions. And so there's obviously a bias in that the people that are the sickest and the worst disease are getting much more aggressive treatment and are more likely to die regardless. So it's really a case-by-case approach with this, and a real, frank discussion with the family and patient if they're awake enough to be able to have that discussion to determine if you're going to, remove an eye in hopes of trying to, essentially save their life with this. And then finally, intracranial extension. This is bad disease. Anytime you have an infection in the brain, it's not good. Really poor survival. Less than 25% survive. So 1 in 4 is going to make it, but the majority are not. And the consensus on management is really poorly defined. All we really have to go on is small case reports and series of some successful craniotomies for salvage, but many really do question the role for more aggressive treatment at this point. And are you truly doing them any good? And I'm more in this boat. I think if it gets intracranial, putting them through this in general probably isn't worthwhile. But there are cases where we will consider it, and we have done it. But it's a really very open and honest discussion with the family, knowing that you may be making them better, but especially in those younger patients without other significant disease, sometimes we try to do everything to try to get them through it. Antifungal therapy. I'm not going to preach to you guys on this. You guys know more about this than I do. It's like having a third year med student tell me how to operate. I'm going to touch on this but you guys are much smarter about this component than I am, especially to any ID colleagues on the line. So as soon as we have any concern for acute invasive fungal disease, empirically starting treatment, both from an antifungal standpoint, but also from typically broad spectrum antibiotics for any secondary bacterial infection, or until we really determine that this truly is just isolated fungal disease. Typically starting with amphotericin plus or minus the other antifungals. And then, we're immediately going to tissue sampling, via either bedside or more commonly the OR. And if it ends up being aspergillus, ends up getting stepped down to voriconazole for at least 3 months, typically monitored by serial imaging as well as our endoscopic exams to determine the ultimate length of treatment. And then Mucor gets upfront induction amphotericin and then stepping down, oftentimes with PASA or isaconazole. However, I think cost can sometimes be prohibitive in some of these, but do seem to have fairly good results. The reversal of the immunosuppression, this is a complex thing and it can't always be accomplished. Hyperglycemia is one of the ones that tends to do better, and it's because it's potentially easier to reverse. But obviously not always. And, I have a low threshold for really arguing for insulin drip until we can get them in a tight control setting and really optimize them. There have been some reports of granulocyte transfusion or stimulating therapies of significant benefit. Not a ton of data on it, but some studies have shown, significant reductions in at least early mortality. So I think it's an area that needs some more work and consideration, but has potential. Hyperbaric oxygen, very limited evidence to support this. It may have some benefit for diabetes, but really probably less clear for malignancy or transplant patients. And then outcomes, how these people do. Well, this is the largest study I came across in really a systematic review, and back in 2013. I think there will be more as we look at all our COVID data and such, but overall, it's about a 50% chance of surviving with this disease. And that's what I quote people. While we generally think of Mucor as being more aggressive, at least in this review, the outcomes and survival differences were not significant between the two. Some of the predictive factors for decreased survival, notably intracranial extension, altered mental status indicating likely intracranial extension, and then renal and liver failure. And those that improved survival were surgery, those that were diabetic, and those that got amphotericin. We don't need to look at all this, but just to highlight, again, the diabetes, those tend to do better overall. Those with neutropenia tend to do really bad. Those with intracranial disease tend to do really bad as well. So what about COVID? So COVID had a significant impact on the invasive fungal disease. And I can remember back to one of our first patients, I believe it was April 2020. And I remember thinking, wow, what are the chances? This 35-year-old guy with diabetes and got admitted to the outside hospital for DKA that also has COVID, just thinking, well, what are the chances? This is just terrible luck. And, what ended up happening was that as we started to go through this pandemic, these case reports of COVID and invasive fungal sinusitis started to really become larger case series that were correlating with the very waves in the pandemic. And nowhere was this more evident than India. India was hit hard with this. And the local media was picking this up oftentimes before it was even in the literature. And they literally had tens of thousands of cases of invasive fungal disease. Not all of that was sinusitis, but a lot of it was, where they literally were converting ENT wards into invasive fungal sinusitis wards. It was bad there. The scope of the problem in the United States, I think, is not as well defined. There's not a ton of literature on it, and I think it's because it did increase, just not to the same degree as it did in India. From our experience, at least in the first essentially 2 years or 18 months, between Georgetown Hospital Center and VA, we make up about 60% of the acute care beds in DC. And on average, this is from my experience, both in residency as well as being here for the past 9 or 10 years, we have less than one case a year, probably one case every 2 years of acute invasive fungal disease. And in the first 18 months of COVID, we had 6, I think maybe actually 7 now. And so while it's not overwhelming, it was a dramatic increase relative to the half a case a year. Why did we have this problem? Well, unfortunately, it ends up being, when you start piecing this down and teasing it out, it's probably multifactorial. Steroids were used injudiciously, notably as we started to become overwhelmed with the virus. Early on, steroids were found to be helpful, but especially in India, when hospitals didn't have room for anyone, steroids were literally being given out just to try to keep people out of the hospital. And so this predisposed to the immunosuppression and really was a setup for invasive fungal disease. Diabetes, we know, is one of the major players and predisposing factors for this. Worldwide, it's huge, and India is number 2 in the globe for uncontrolled diabetics. Obviously exacerbated by the steroid overuse, and so this further compounded the problem. One thing I didn't highlight here, as newer medications started to be developed too, the immune regulation of some of these probably played a part as well. That's less well understood. And then finally, direct COVID-19 altered immunity. And some may say, well, couldn't you just account for some of these other factors? But there's numerous studies, especially in India, that have come out that show, well, there's these people with relatively otherwise healthy with mild COVID, no diabetics or comorbidities, but they're still getting this invasive fungal disease. And it really points that it's something going on with the COVID that does this. And, we're continuing to understand COVID-19, and still there's an issue with us, obviously. But we do know it has many effects on the immune system with dysregulation and altered interleukins and cytokines, reduced CD4 and 8 counts, as well as impaired phagocytic immune cell response, which is probably really important in clearing any fungus that's being, breathed in. How we managed this was obviously, we didn't know how to manage this early on. And one of the big things from our standpoint, this is a letter in the Journal of Neurosurgery, but it was based on an email that went around widely to the skull-based surgery, groups, and ultimately to ENT, and really became a guiding kind of or concern for us, where these anecdotal reports from colleagues in Wuhan were operating on skull-based patients, so pituitaries, essentially endonasal cases. And despite appropriate PPE, PAPRs or N95s, every single person in the operating room was getting COVID. And this was very early the letter was published later, but these reports coming out, late March, early April. And so it caused a real significant fear in how are we supposed to manage these patients if we can't protect, ourselves and the staff who's working here. And so we really didn't know it was safe. Operating with PAPRs, operating with N95s. There were some institutions where ENTs were refusing to operate unless they had an N95 and a PAPR on. And so, it was just a level of uncertainty of how we dealt with this. The variable presentations of COVID were hugely, complicating too, is that some people had just a little something when we couldn't tell if they were going to crump and then they're going to start to develop more significant lung disease. Earlier reports were really saying anyone that had emergency surgery with COVID just did much poorer overall. So we didn't know. Lack of medications, notably in India, there was a whole black market amphotericin thing that we had one patient come over from Pakistan that, he had gotten some version of amphotericin. We had no idea the concentration. It was, when you run out of these critical medications with dramatic, overwhelming numbers, it significantly impacts your ability to treat them. Late presentations. Many times we were not getting people because we didn't have room in the hospital. And so they end up getting waitlisted until, okay, now it's really critical. We finally get them in. But at that point, a lot of times the disease was in the brain, and there wasn't a ton we could do, and our chances were just much lower. And we had several patients that came in late, had some kind of, again, those non-obvious prodromal symptoms, but they were worried about COVID, hematologic malignancy patients, older patients. So this was a factor. It's one of those secondary side effects of COVID in the non-COVID population. This was our first patient that we had in April, and this is a 35-year-old guy, diabetic, that was seen at outside hospital. He basically went and admitted to the outside hospital for his DKA and found incidentally have COVID, no significant lung disease, and he eventually was discharged as he was starting to develop a little bit of sinus symptoms on the left side. And they said, "Here's some antibiotics, go home." He came back a couple of days later with periorbital cellulitis. And they said, okay, we'll admit you. They got a CT that was a little bit concerning of maybe infection spreading to the eye. They tried to transfer him here, but we were on red light for a while. And after almost a week, we finally got him over here. And by the time we got him here, he had, this loss of contrast enhancement, extending a little bit to the eye, but notably to the brain here and frontal lobes. He had intracranial disease, and he was still testing COVID positive. And we didn't know what to do. We had many discussions with our ID colleagues and the group as a whole, in the setting of the concern of that letter that I talked about, and how do we manage this? And initially, especially on this first patient, we said, okay, we'll wait till he tests negative. He ended up testing positive for weeks. And eventually, as his disease progressed, we said, okay, we're going to take the risk. We're going to use every precaution we can. We're going to use a smoke evacuator or suction evacuator right by the nose, so we can try to minimize this. And so we took him, but at that point, it was unfortunately too late, and his disease just kept progressing and eating away his frontal lobes. And he eventually was discharged to hospice. And the reality is his likelihood of surviving, even at the beginning, was low to begin with. As we move through this pandemic, our management has definitely evolved, and it's become less hands-off to much more closer to normal. And I think one of the key things is a lower threshold for the suspicion of disease. Within that group of patients, of the COVID positive, 3 out of the 4 had intracranial involvement, 3 out of the 4 had orbital involvement, and 3 out of 4 died. For those without COVID, notably one had intracranial involvement, and 1 out of 2 died. It really fits with the numbers here. Outcomes abroad, these are misleading. So a lot of the outcomes in COVID with invasive fungal disease, people were trying to pump out literature to get the word out there and to try to get as much information out there about it. And so the results of these are surprisingly good, and I think artificially good, because the follow-up is so short. But as you can see, these were cases. This one institution had 131 cases, and this is like in a 4-month period. And you can also see by the fact that they were catching these patients without CNS involvement, that they were catching them very, very early. And so part of it, when it was so common, people were getting scanned earlier, they're getting intervened on earlier, and getting treated with medication and aggressive treatment at an earlier stage. And so that's really my argument for treating these patients as early and aggressively as possible, because the earlier you get to them, the better they can do. And I think earlier recognition is key, and it's tough because when it's a less common disease, it's tough to pick up. I think as we move forward, I think we can look as increased immunity with vaccine or prior infection, as well as improved understanding of the disease and better treatments for the COVID, as well as improved recognition of the risks of developing this, that we can go back to a more normal picture here with invasive fungal disease. In conclusion, most fungal disease is not invasive, and it presents most commonly with chronic sinus symptoms in the overwhelming majority of people. Surgical intervention is a key component for all forms of fungal disease. And acute invasive fungal disease is rare, but typically a devastating disease. And multidisciplinary care is extremely critical to really get the best outcomes here. COVID-19 increased the prevalence via multiple mechanisms, and I think improving our understanding and treatment of COVID-19 will hopefully improve our outcomes here.